Dr. Barrows is a board-certified family medicine physician with 25 years of experience treating all ages and stages of life. She currently sees female patients from teenage years to menopause for cycle and reproductive issues such as polycystic ovarian syndrome, PCOS, and insulin resistance, endometriosis, recurrent miscarriage, poor ovulation, PMS, postpartum depression, and irregular or heavy cycles. She's frequently sought out for treatment of recurrent miscarriage and infertility, and by young women seeking to optimize their natural cycle. She's a popular speaker on topics related to the female reproductive system, necrotechnology, and restorative reproductive medicine. Dr. Barrows earned her medical degree from the Medical College of Ohio, University of Toledo College of Medicine and Life Sciences in 1999. She completed her internship and residency in family medicine at the Medical Center in Columbus, Georgia in 2002. She then was blessed to travel to many different states as a military wife, enabling her to practice in diverse settings, including pediatrics, urgent care, family medicine, and women's health. In 2013, she completed the medical consultant training for necrotechnology at the St. Paul VI Institute for the Study of Human Reproduction. After moving in 2013 to Grand Rapids, Michigan, she started a busy women's health practice featuring necrotechnology. Dr. Barrows is proficient in interpreting many forms of natural family planning, including the Creighton model, Marquette, and symptothermal, as well as other methods. Dr. Barrows is happily married to a retired Air Force officer. She and her husband have 5 children, and they live near Grand Rapids, Michigan. Dr. Barrows volunteers in the community at a pregnancy care center, and she also enjoys singing with a choral ensemble called Gaudete. Please join us in welcoming Dr. Barrows to the NFP Podcast.
Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast.
All right, guys, welcome back to the podcast.
Hi, everyone.
Today, Emily and I are really excited to have on with us Dr. Kimberly Barrows. She is a physician who's going to be speaking with us today about a really exciting topic, which it's also a sad topic, but exciting in that she's very knowledgeable on it. So hopefully we'll get a lot of good information, and that is the topic of recurrent miscarriages. So welcome to the podcast.
Thank you. I'm really excited to be here. And while it is a difficult topic to go through and to talk about sometimes, I am really excited about it because I think there's a lot of hope out there. So it's not just a downer all the time. There is a lot of hope for women. And I really hope that this will be a shot in the arm of encouragement to those women that you're heard. We know what's happening. We don't always know why, but we're going to dig deep to try and find why.
Right. That's really encouraging to hear, because I think right now a lot of times it's, well, we just don't know, or it just happens, it just natural process. It just keeps happening, which can be very discouraging, especially for someone who really wants to have a live birth and get all the way to the end of the pregnancy. So yeah, we're really grateful that you're here today to help us tackle this topic. Let's start with just kind of a brief introduction. Tell us a little bit about your background and how you got into this field that you're in now, kind of focusing a little bit more, working with patients in this specific area, and where you're practicing medicine right now.
Yeah, I am a board certified family medicine doctor. I trained in Ohio. I was introduced to a lot of great people that were involved with things like fertility awareness-based methods and natural family planning kind of early in my medical school years. So that was something I actually started looking into, but not wasn't really taught through any formal channels as of yet, through medical school, residency. There weren't too many people that knew about it. I was able to talk to others who didn't know much about it, which was great, kind of educate some of my peers and even some of my attendings and professors. But that's was something that I was really interested in because I thought, well, this sounds much more healing to women or empowering to women than saying, well, you've got a problem with your cycle, but we can put you on a birth control pill and that can kind of suppress the problem until you want to have a baby. And then, of course, you'll have to go off that birth control pill. But then we might be able to do something to help you, like IVF or something, or some other strong stimulation drugs to help you get pregnant. And to me, I thought, well, that doesn't seem to be the way we're doing the rest of medicine, when we're studying other GI issues or cardiology issues or anything else. We're kind of looking for the root cause. We always are looking for what is the underlying cause if we can find it and treat that first. And so I felt like women's health had a lot of area to grow. And I was so grateful that I got to take some training. So the first training that I got was in nephro technology. That was in let's see, that was in 2012. And that was at in Omaha, Nebraska. And then secondarily, after that, I was able to have some training, uh, fertility, all areas that are involved for the reproductive. And those areas have many different approaches, just like there's many different kinds of doctors and many of ways to skin a cat, so to speak. But we can come up with a lot of different ways to treat these things that all work in harmony with the cycle.
Yeah, that's so great. It's great to hear that so many more medical professionals are getting training in a different approaches to a restorative approach to medicine. Because I know at least, and this wasn't I haven't been in this arena for very long, but over the decade plus that I've been in it, I remember at the beginning, it was very like siloed. You were a medical professional trained in this one method. So you could only see patients who charted this one thing or vice versa, and so everyone was kind of in their group, which is kind of frustrating as the patient because then it was like, okay, every time I wanted to switch doctors, maybe because my insurance didn't cover something or we moved or what have you. Well, now I have to like go and take all the classes and learn this new method of charting and do it this way so that this doctor could now read this chart. And it just seems like medical professionals are more holistically trained to just say, I am trained in this one way, but I can still kind of interpret charting even if you use a different charting method. So that's really, exactly. I think, yeah, very encouraging as the patient anyway, to hear that. So, okay, excellent. So this was something that you were kind of on board with even before you graduated from medical school, which is definitely unique. That is not something that we hear a lot about. It's funny. There's the story in the patient world, and I think there's a story in the medical world as well of, in the patient world, Emily and I talk about how there's the women that we've always worked with that come to us when they're 30 and they want to be pregnant yesterday and they know nothing about their body, and we just teach them kind of the basics of how ovulation happens and how conception takes place. And they're like, mind blown. Like, this is brand new information. No one ever told me about this. And I feel like in the medical world, you have the same thing with medical professionals who go all the way through medical school, go all the way through their specialty training. They get into practice and then somehow they stumble upon, learning about fertility awareness, learning about these restorative reproductive approaches. And they're just like, I spent all this time in school and I never learned about this. I didn't know all of these things even about the body or about these treatment options. So it's great that you were able to kind of hit the ground running, already aware of all that and educate your peers along the way. So let's focus on today's topic then, talking about recurrent miscarriage. How did you kind of start working with, patients with this specific, I guess, diagnosis, if you will? I'd like to hear kind of your story into this demographic. And then also if you could define what it is we're talking about when we say recurrent miscarriage.
Sure. Yeah, there are a number of professional organizations that try to define recurrent miscarriage. And still, I don't think there's total agreement, but I would say the majority of the medical world seems to agree now that it doesn't have to be 3, but 2 miscarriages would qualify as recurrent miscarriage. Though many of the societies will still say 3, I think most doctors are realizing, especially if there's 2 subsequent, consecutive pregnancies that end in miscarriage, and even more so if a woman has never had a live birth before. But sometimes it can be it can still be kind of concerning when you see two miscarriages after some live births. It's similar to secondary infertility. That can still be a big struggle, even if you've had some live births. So it would be usually two miscarriages. Not They don't have to necessarily be consecutive either. There can be a live birth in between, according to some societies. And we would say that we would estimate right now, they estimate that 15 to 20% of pregnancies end in miscarriage right now. But then there's somewhere about 1 to 5% of couples. So of all couples that are trying to have children, 1 to 5% of those couples are experiencing multiple miscarriages, not just one. One, as we know, is fairly common, 15 to 20%. That's pretty common for couples, but 1 to 5%. And we know it must be higher than that because the number of miscarriages is higher than what we know. So the number of recurrent miscarriages is higher as well. And I think my journey into this actually was accelerated by my own experience with miscarriage. So as a 39-year-old, I had a miscarriage. And I had already had three children, but finding out that, oh, wow, we waited kind of a little bit after having the first three, and now maybe I'm going to be having trouble. So after my first miscarriage, I was able to have that evaluated a little bit by my OB. We got a progesterone level after my peak day that was identified with a fertility awareness-based method. So that was a lot more accurate than just going in, say, on day 21 and assuming that I'm having exactly ovulation right on day 14. And it showed that it was too low to sustain a pregnancy, he said. I was like, okay, well, we've got to do something. I need to do something about this. I need to find out more. And that's when I found out about the National Center for Human Reproduction, which is in Omaha, Nebraska, that teaches the Creighton method and naprotechnology. I was able to actually contact them first as a patient and have some treatment so that my next pregnancy at age 40 was a full-term birth, and also was really grateful to have another pregnancy at 43 that also ended up in a full-term birth. So, and at the time, yeah, I had friends and patients that were struggling with miscarriages. And so that was something that I really wanted to learn more about. And that's when I was just about to be pregnant with my number five, that's when I signed up for training in Omaha, Nebraska. And then it was kind of funny because then I found out I was pregnant. I was like, oh my goodness, wow, I thought I couldn't do this, I couldn't do the intense training if I was pregnant, but it totally worked out. So
Wow.
yeah.
Wow, that's amazing.
What a
That's absolutely amazing.
beautiful story. What a beautiful story.
Yeah, that's really great. So, if recurrent miscarriage then is, at least two miscarriages, usually consecutively, but not necessarily. And then, in your case, you mentioned that a simple blood workup just showed your progesterone level wasn't high enough for whatever reason during that post-ovulatory time to sustain a pregnancy. And in that case, right, it's the progesterone that keeps the uterine lining, supple, sufficient to sustain life once it's implanted in the uterus. So when we don't have sufficient progesterone, the lining is not there to support the baby. And so the baby would not be able to develop correctly or be sustained. And so is that something that you would say is more of a common cause of recurrent miscarriage? I mean, something so simple as just a progesterone level not being correct. Has that been your experience, or do we have any research as to kind of what's the most common underlying cause, or what are some of the underlying causes of women having recurrent miscarriages? Because I know Emily and I both have talked with women who've had many losses, even after having multiple children. They go on to have many losses and have a really hard time trying to carry to live birth.
Yeah. And I would say my story, I probably didn't explain everything. In addition to the low progesterone, I don't think it's very common that it's simply one thing, that it's just low progesterone. So I had worked a lot on insulin resistance because I knew that having a family history of diabetes, being born actually prematurely and being small for gestational age myself, which is another risk factor that we don't think about for gestational diabetes and then regular diabetes. If you're small for gestational age or you're large for gestational age, it indicates that there was something going on with your mother's placenta, and that genetically imprints on you. It's like epigenetics. So, plus the environment that you grow up in and what you eat and things like that, which we ate pretty well, I think, but I think that more processed foods were sneaking into the American, food system. So, in that time frame, so there were a lot of things that I knew I was, and then I had gestational diabetes with my first pregnancy, so I knew I was at risk. I was really working hard on that. And so with most couples that we evaluate, I would say there's 4 to 6, and research has shown this, 4 to 6 underlying factors. So it's not just one thing. Yeah. So my husband was also working on his health as well. So we weren't just kind of sitting back and hoping that one little prescription was going to help, but we were kind of taking a holistic approach on our own, as well as getting help from the National Center for Human Reproduction. That was super helpful to have them to guide us on how to do that further. Oh yeah, age is a big factor.
Okay.
Yeah, it was a factor for me, and it's not obviously something that you can change, but you can change your health a lot, and especially your metabolic health. So the whole predisposition to diabetes and insulin resistance, we estimate that 93% of adult Americans have some metabolic dysfunction, and that affects insulin production and glucose regulation and mitochondrial function. All those things are linked together. And so looking at both the husband and the wife for that is really key. We also have other lifestyle factors that we know are impact miscarriage, and those would be obesity, being even just a little bit overweight or underweight can make a difference. So maybe losing 5 pounds or gaining 5 pounds, if the case may be, that can actually help you produce more hormones and have a lower inflammation. Smoking, vaping, and those kinds of things are not good for fertility, and so affect miscarriage. And excessive alcohol use. I would recommend actually no alcohol around the time of ovulation, because that has been shown to even block ovulation for women. So even if it doesn't completely block it, but if it so to speak weakens it, you're not going to have as healthy of an egg ovulated. You're not going to therefore have as healthy of an embryo. But we know it also affects the sperm, so it's not just women. And there's about a 70 to 90 day window where both the egg and sperm in the male are going through their last, well, for the egg, it's her last maturation process, because we know we have all of our eggs from the time of birth. But for the man, he's developing those new sperm that are going to be released in 70 to 90 days. So that time frame is really important for both husband and wife to really pay attention before they try and conceive on their health. And I really work with, when I meet couples that have had up to 12 miscarriages, I've had some patients with that many and never a live birth. And I tell them, I don't want you to try and get pregnant right now, just because I don't want this to happen to you again. And I don't want it to set you back. I know you'd like to have a baby in your arms right now or last year, but let's just take this time to work on both of your health, and then we're going to have much better results. Now, sometimes that doesn't happen, and I do meet women like the one that I'm thinking of that she had 12 miscarriages and was pregnant with number 13. She was 40 years old and had some other medical issues. So she was, it was like a rescue mission. And yet she now is cradling a healthy baby boy. So there is hope.
Wow, that's amazing. That's absolutely amazing. Okay, so I took some notes here about kind of the underlying causes. Can you speak a little bit to, I understand the lifestyle factors, age, obviously we can't alter. Now, what if, aside from my age, maybe I'm, 30, my mid to later 30s, or anywhere in my 30s, really, maybe you can define kind of what would be an older age that's then we're starting to see more frequent miscarriages at, like what age that is. And then also, aside from lifestyle factors, what are some other factors that women experience? Like, are there symptoms, or are there diseases, like genetic things? Are there blood clotting issues? Are there, what are some issues that women can have physiologically speaking, that they might not be aware of that are connected to frequent miscarriage?
Yeah. Age over 35 increases your risk for miscarriage. That's one time frame. But then over 40, it increases it even more. So it does go up somewhat gradually, but there are some little jumps kind of at those ages. Um, However, we are seeing a lot more women trying to get pregnant around that age. So there still is a lot of hope, a lot of things we can look at. One of the other things I like to look at is, of course, we start with the anatomy. We want to make sure that everybody's anatomy is okay. So that means evaluating the husband for a full physical exam, maybe including also an ultrasound. And then the man also will have some hormones tested because there are hormonal issues that affect men. If he has too high of estradiol, too low of testosterone, that can be a problem. And even if he's taken exogenous testosterone for whatever reason, for bodybuilding or whatever, that actually can affect you. So, I recommend that guys stop that immediately and let's figure out some other things we can do to improve their hormonal health. And the good news is you can improve their hormonal health, but it may take some months. There's For the woman, of course, you need to make sure her uterus has a normal uterine cavity. We don't have a septum or something in there. And that the fallopian tubes are open. So we usually can do that pretty easily with a hysterosalpingogram, they call it. And that's a dye test that puts dye through the uterus and then watches for the spill through the tubes. And if you have someone that's really skilled, they can do one tube at a time and watch the type of peristalsis that happens, the movement of those tubes that happens naturally, and they can actually diagnose whether there's a slight problem or not, that they're not moving properly. And that would be something that even if they're open but they're not moving properly, it would be something that they could look at with a diagnostic laparoscopy, which is a surgery that has just tiny little incisions in the belly, to take a look with a camera and see if there's some reason why those tubes are not moving properly. And one of the reasons that could be is if she's had a pelvic infection in the past, or if she's had any kind of abdominal or pelvic surgery, that sometimes after surgery, the way we heal, we cause some adhesions to form. Our bodies cause adhesions, which are sort of like filmy, membranous, like almost scar tissue. And you can have endometriosis, which endometriosis is so common in the people that I see for infertility and recurrent miscarriage. And it's something that we don't want to miss, but it's often missed because it is not always associated with the kind of debilitating pain that we hear about. About half the women that I see will have some kind of significant pain that makes me think, oh, we should really look into that. But then the other half of the women, I know that just because of their obstetric history, either they haven't had a baby or they've had a lot of miscarriages, they've had trouble getting pregnant, that we really need to have a surgeon who's specialized in endometriosis look for endometriosis. It's not always going to be found on just a general real quick surgery. We need someone who has done additional training in minimally invasive gynecologic surgery and has all the techniques for not only a near contact approach to look for all the subtle signs of endometriosis, but is going to excise it and repair those defects so that it's almost like plastic surgery of the pelvis. We've actually got a pelvis that's healthier and where things are in better alignment and moving better than it was before.
Wow, that's so interesting. Can we hone in just for a second on age? Why is it that age is a contributing factor to recurrent miscarriage? Is it that eggs are getting old, so when she ovulates, it's just a quote unquote bad egg? Is it that her, body's starting to break down, her uterus just isn't as healthy as it was when she was younger? Like, what is it about age that impacts, the ability to carry to live birth?
It's both of those things, and also for the man, that we don't have as healthy of eggs. The man may not have as healthy of sperm. The uterine environment may not be as healthy because as she's gotten older, blood flow may not be as good to the ovaries and the uterus and other important parts. Same with the guys. we know that having an abnormal semen analysis, and that's something that we really should make sure that's done at the beginning of the workup for recurrent miscarriage, because we don't want to forget about the male factor, which is there at least half of the time. It's not the only cause, but it's there half of the time. We when we do a semen analysis, we see abnormality. We can definitely improve that, and it's really important to do that because he is half the genetic makeup of that embryo, right? So if his genetic contribution isn't as healthy, then we're going to have problems with miscarriage as well. So we need to remember that. I would say for women, we also have the whole hormonal issue, which is probably more prevalent in women than men as far as seeing hormonal abnormalities, though we do see it in men. And so as we get older, we're either less not producing as much of those hormones, or we're resistant to it. So you can be progesterone resistant, and that means that then your receptors need more progesterone in them to give the desired effect of keeping that lining, thick and healthy and sustaining the pregnancy. You can have insulin resistance, which both men and women suffer from a lot, and you can have other hormones that can be off. You can have too much prolactin in both the man and the woman. You could have estradiol can be high or low, and that can be a problem for the woman, but it's also a problem for the man if estradiol is high. So there's a lot of other things that age has to do with. There's also infections that maybe when we're younger, we hadn't acquired these because they may be due to recurrent miscarriages. Actually, they can be due to you're holding on to a pregnancy that you don't realize is not viable anymore, where the baby has died. And so, but then it's called a miscarriage when you don't have the automatic symptoms of cramping and bleeding and know that you're having a miscarriage. Well, sometimes it's not until the 10 or 12-week ultrasound, perhaps, that you see that, oh, this baby is only about the size of a 6-week embryo. It died 6 weeks ago. That's been sitting inside her uterus for a long time, and that can give way to infection. So there's a very subtle infection that most of us probably haven't heard of, chronic endometritis. So of the lining of the uterus, which is called the endometrium. And so itis means inflammation. Usually it's actually inflammation from an infection. And it's so subtle, it's very difficult to diagnose. So we usually have to do an endometrial biopsy, which is not too hard of a procedure. It can be done in the office without anesthesia. It isn't a terribly painful thing or anything. Causes a little bit of cramping in most women, but not anything terrible. And then it needs to be sent to pathology, though, and stained for some really specific cells. And the other way you can also look at it is you can send it to an outside lab that will look for a full microbiome of that tissue. So it will look for good bacteria, the good lactobacillus that you want to have, as well as the pathogens. Now, some of those tests, like the microbiome tests for both the gut or the endometrial tissue, those kinds of tests are often out of pocket, which is really tough because it can be expensive. But if you can have one of those tests done, that can help you direct the treatment even further. But most of the time, even with the test that is done at the hospital lab, the pathology lab, we could give a good treatment for chronic endometritis. It's just that we've got to have a high threshold of thinking about it, and then we've got to test for it.
So is that something that you're thinking when a woman comes to you and has had frequent miscarriages? It's like, okay, we need to investigate if she has any type of, infection or medical, something has happened physiologically because of this. We should look in to make sure that, she's healthy.
Yeah, definitely. And even if she doesn't have any known risk factors for infection, it's still in the back of my mind because it's something that I know she won't have symptoms from. So other than maybe recurrently losing a baby, the same way endometriosis, which sounds very similar, but is different, that endometriosis, she often may have no symptoms except for either trouble getting pregnant or losing a lot of babies. And it can be even further along. You can have second and third trimester losses that can be affected by the chronic endometritis from a previous miscarriage. So I think it's really important to look at these things and treat them when we can so that we don't have further problems.
Right. That's so interesting. Let's just take 1 second and talk a little bit about male contribution, because I just find this fascinating. And this is clearly just my ignorance, but just thinking about it, the only thing I could think of male contribution having a factor with recurrent miscarriage. To be honest with you, I really just think of it as like it's got to be something with the woman, right? She's not able to carry the baby. So, in what way, could the woman be completely healthy, or is it usually if it's a male contribution, it's also something with the female? Is it usually both, or could it be just solely a male thing where his sperm are just not that healthy? So every time an egg is fertilized, that baby's just not healthy enough to grow. Or is it something else? Yeah, let's talk a little bit. Like, what is the male contribution to recurrent miscarriage?
Yeah, well, we know that the male contribution is he does contribute half the genetic material, right, to the embryo, and that has to be healthy. But there's genes that turn on and turn off throughout our whole genome, more than we can ever know about right now. But those we have to have proper functioning of all those genes too. So those are the things where imprinting happens in the male's body when he's developing those sperm, and certain things can be affected in the way that the genome turns on different parts, turns off different parts. So we know that the genetic part is a big contributor, and it's not just his sperm only, it's his whole environment of his body and how healthy he is. There are also, we didn't talk about like autoimmune disease, which obviously affects females more than males, but it can affect males. I've definitely had males with autoimmune disease, and that also leads to blood flow problems. Sometimes there are thrombophilias, they call them. So the propensity to clot can happen. And those think about the tiny little arteries that lead to the embryo in the uterus, or even that are surrounding the ovary that feed it before it ovulates that egg, surrounding the testes before the sperm are while the sperm are developing and before they're released. Those make a big difference. So we need to do a really thorough look and history in what's going on with the male. Do some more testing than what we would typically get, which is, I think most of the time people look at two things: testosterone and their semen analysis, and that's about it. So I think we need to do a better job for those guys.
Now, I guess I'm just thinking of, is it too early then if a couple miscarries their first time achieving a pregnancy? Is that too early to start saying, hey, I want to know why I miscarried before I try to achieve? Or is it more like, well, that could just happen and let's just try again? Is it really not too much of an investigation done until after we have that second miscarriage? And then it's like, okay, well, now maybe something could be wrong. Does that make sense? Like, how far down the line do we have to go until a couple should say, oh, I kind of want to get this checked out?
Well, I think it partially depends on the couple, and I'm sure it depends on what their time frame looks like. How old are they and how long have they been trying? And I definitely would accelerate a workup, I think, more on a patient that was older and maybe had a lot of time trying and maybe didn't have as many more healthy, fertile years ahead of them. So it really depends on, it's kind of a shared decision-making thing with the couple, and there's layers of the onion, and I wouldn't necessarily recommend that we peel back every single possible layer and pay for every single test that and put them through all that for one miscarriage. Just depends on the couple. But of course, if they were someone that was in their 40s and they were hoping to have a larger family and they really needed to kind of get going, then we might do a further workup and say, let's wait these 3 months and look into these things. I also would reassure them, though, especially if they're younger and they hadn't had a lot of trouble getting pregnant, that, hey, we can do a basic workup, but most likely you're going to have a healthy pregnancy the next time. In that case, the younger couple that hadn't been trying a long period of time. But I think that's the other thing. We need to not just think about age only, but we do need to think about how long had they been trying. Because I think people that have been trying for a while and they're in the category of infertility, meaning they have had a whole year of random on non-contraceptive intercourse, or they've had 6 months of fertility-focused intercourse where they know when they're fertile and they're targeting that fertile window without using any contraception. I think those couples are in a different category than the person who got pregnant or easily miscarried their baby, but didn't have any trouble getting pregnant.
I see. Oh, that's really interesting. Okay. So, can you just give us a little bit of a snapshot then? Because obviously you are a physician that's trained to investigate underlying causes. So we call this category, right? Like that restorative reproductive medicine approach of why is this happening? Let's find a root cause. Let's fix the bodies of the male and the female. Let's help get you healthy so you can go back to having just a regular active intercourse, conceive a baby, and carry that baby to live birth. What is the difference in the treatment of recurrent miscarriage if a patient and a couple were to go to someone like yourself who's trained in the restorative approach versus, let's just say, the mainstream medicine, OB doctor who's not aware of kind of investigating the underlying causes? What do those two different treatment paths look like right now?
That it really varies when a person goes to either their family doctor or their OB to say, hey, I've had a miscarriage or I've had several miscarriages. Some doctors are going to do more of a workup than others. But one thing that I've seen is, at least in the European guidelines for reproductive health, they do recommend going to a specialized clinic for evaluation of recurrent miscarriage. And while I'm aware of only a few specialized clinics here in the US, I would say that actually RRM physicians are specialized clinicians. And so any clinic that they work in is a specialized clinic. So that's where I think we really need to go. I think that you can get a basic workup with your family doctor, your OB, but there are a lot of things that are probably not going to be some of the layers of the onion peeled all the way back. So I think it's really important to do that. I would say usually they're going to look at your TSH to make sure your thyroid is functioning well. They may look at a progesterone level, or they may look at your glucose level to see if you have diabetes. But there are things like subtle insulin resistance that goes along with PCOS. Even if you have that diagnosis and you may be treated already with something like metformin, there are other things that we can do to improve your metabolic health. And sometimes that's not done, but oftentimes a glucose and an insulin 2-hour glucose tolerance test with insulin, even better, is not done. So I think those kinds of tests, you have to have a lot of coordination with your lab too. So if you're not used to doing those tests and you might not even know what to order, or at least you haven't worked it out with the lab that you work with so that they do the test right. So I would say you can save a lot of time and sometimes wasted energy by talking with someone who's specialized in that, looking for an RRM clinician.
Okay, so it's not that maybe a mainstream non-RRM physician wouldn't know about, certain tests. Like they would still kind of try to investigate and figure out why, but they just might not know, have the broader knowledge base to investigate and to dive a little bit deeper. And they might just not have those resources or kind of that background, even to just like the current research, right, about different things that are being investigated for underlying causes. So it still would be more helpful, even if you have seen, kind of the mainstream medicine physician, and then they've kind of come up short in that they just say, like, I just don't know what else to do. Like, I've done everything I know to do. I don't know why you're still miscarrying. It might be, not to lose hope. It might be still encouraging to then let's go see someone who is has that more restorative reproductive medicine approach, because there might still actually be more investigation that can be done to find out why. Is that probably accurate?
Yeah, and I don't think you're going to lose anything by going to see an RRM physician. In any case, they're going to help you with improving your health, and they're going to give you the sense that, okay, we've left no stone unturned, even if a baby doesn't happen for you. But I think in the majority of the cases, there will be, a lot of things uncovered and then a successful pregnancy. So I would say don't give up hope. Your family doctor, your OB can be a really trusted partner in this. Sometimes they can give you a referral for that. Sometimes they can also, they're going to be the ones that are supporting you often in the usual prenatal care and delivery, and if there's any surgery that's needed, that's later in life, those kinds of things are really where I feel like our OB, GYN colleagues that aren't RRM trained, everybody has to specialize in something, and so a lot of them, they've really specialized in that gynecologic surgery that may not be specifically endometriosis surgery, but not maybe, but other things, and then in the birth process and lots of other things like that. So I would say definitely try and partner with your doctor and see if they can also refer you if you need that for your insurance, but many times you don't need that for your insurance. It will just, you can just start seeing them, and usually it's often very much like a same as a primary care visit as far as insurance coverage. Now, there are some RRM physicians that are finding, because of the long amount of time we spend with people and the deep amount of research, the hours of research that we do for studying these different cases and what we can do for them and collaborating together in grand rounds and different things like that. Some of them are actually doing a membership. They're finding that doing a membership for people is actually better for them than having to struggle every time we want to do one thing to see, is it going to be covered by insurance, and what do we have to say to prove that, and different things like that, and then end up maybe with a surprise bill because they thought it was covered by insurance. Doing a membership is more of a way to kind of know what you're going to be paying. So some of the physicians have gone into that.
Okay, that's great. Emily, why don't you jump in? What questions do you have?
Yeah, I'm wondering, you talked about so many underlying things that the woman could be experiencing. I'm wondering if you could talk about how perhaps charting the menstrual cycle could help, a woman identify or see things ahead of time that might contribute to recurrent miscarriage.
Yeah, that's a great question. I am really very positive about having all my patients chart with a method that has a certified teacher, because I know that the woman will be empowered to see abnormalities, and the charting instructor is really great at picking up those things that can be more subtle. So for the woman, she's going to notice, once she identifies her peak day, whether or not her luteal phase is a good length or not. It should be at least 9 to 16 days. And if it's not in that range, then we're definitely concerned about, okay, how is the production of those hormones that are super important for implantation and then furthering on with the pregnancy, both progesterone and estradiol. And they need to be in the right ratio too, with progesterone being higher at that point than estradiol, but estradiol is still a really important part. And so it can't be just absent. And so we can have a hint at that if we see a really short luteal phase. Also, if we identify peak day, and from peak day till the next bleed is called the luteal phase, sometimes in that luteal phase, you'll have bleeding before the actual period starts, a little bit of spotting, or after the red flow, then you'll have what's called tail end brown bleeding. So after the red bleeding, you have some brown spotting for several days, and that can be indicative of a number of different things, either hormonal imbalance or sometimes that infection that I talked about. It can be a mild either cervicitis or chronic endometritis that is not symptomatic. You may not have a vaginal discharge that tells you, ooh, something doesn't seem right here. It seems like an infection. You still could have infection without knowing that. Another thing that you can calculate is when you're looking at the buildup after the bleeding. You should have a gradual buildup of cervical mucus that gets gradually more clear, more stretchy, and it should last for 5 or 6 days. And some people either have a very weak amount of cervical mucus, or they have a short, only a day or so of the cervical mucus. And a good teacher, as well as an informed woman, can notice that, okay, my mucus cycle is also not optimal. So there's a lot of things we can do to optimize that too. And our teacher can help them with some of the things that can optimize that as well.
That's really encouraging, I feel like, for women to kind of know what questions to ask, maybe in those doctor's appointments, when they could say, like, I have this charting, these are some of the things I'm seeing, just to kind of give the physician a heads up too, especially I think that tail end brown bleeding and just, limited cervical mucus, just all the things you spoke about. I'm curious, I feel like we could elaborate on a number of things that you just mentioned. So not to change, the direction here, but I do have a question about, I'm wondering if anyone has been able to identify or research has been done, do we see a connection between previous contraception use and then this recurrent miscarriage diagnosis, so to speak?
Yeah, I don't know if there's been a lot of research in that area. Probably because contraception use, it does seem to be so ubiquitous through our society, that it would be hard to tease that out. Find women that have never used any contraception is kind of tough, but there are women out there. But the thing is, we do know that when someone has something like endometriosis or PCOS, and someone that's been on an ovulation suppressing contraceptive, some kind of hormonal contraceptive, like a birth control pill or an implant, the Depo-Provera shot, or even an IUD. One of them does have hormones in it. The other one doesn't, but it is supposedly supposed to suppress ovulation as well. Then that just allows the problem to get worse under the surface as they're aging. And then when they go off of those, then there are a lot of problems that if they would have been addressed when they were younger, it would have been a lot easier to address. Just like all kinds of health problems. If you cover something up and don't look at it for years and years, and then you want to look at it, it's probably going to be worse than if you would have taken care of it right away. But women don't know that, and they actually think that they are taking care of it. And so I don't blame them for that. They are going to their doctor asking, what can we do? And that's something that's prescribed for them. And so they are thinking that, okay, good, I'm taking care of the problem, I'm being responsible. And then when I go off of it, I'm sure things will be fine. And I think it's a big shock when they find out that's not the case. And that's heartbreaking for all of us.
You're so right about that. I think in the women that we work with, we've talked about this, they're not expecting to be dealing with the issues that they're dealing with. I don't know what I've often asked women and couples, knowing that you were put on this, did anyone ever say, okay, when you're ready to have babies, this is what we're going to do? And no one ever says that was ever talked about, And so I think at the time that they start taking the contraception, they're not thinking about babies anyway. So it's not even part of the thought process. But I think a lot of women and couples feel, I don't know, I don't want to infer what they feel, but I think it is hard to sit with all that information.
Do you have any more questions on that?
I'm curious about just because I'm thinking of a couple of friends that we have who experienced recurrent miscarriage, and one of them in particular, I'm wondering how often you notice clotting disorders and I'm talking like 7 and 8 miscarriages. Does that seem to be common at a certain point of amounts of miscarriages, or is it really, can it really be a number of all of these things that you've talked about?
I think that clotting disorders are more common than what we realize. They're usually not looked for. And a lot of societies like the American Society for Reproductive Medicine or the ACOG or the European group called ESHORE, some of them would not recommend a full thrombophilia workup or blood clotting disorder workup. They would look for antiphospholipid antibody syndrome. They might look for factor V Leiden, but some of the more minor ones are not looked for because when they isolate them one at a time in research, they may not show a statistically significant increase in the risk of miscarriage. But the thing is, when they're combined with other things, such as insulin resistance, or such as 2 or 3 different minor thrombophilias, or other hormonal imbalances, that can make a big difference. Or if there's an anatomic problem where, okay, you could have a baby, things aren't perfect here. We've got maybe some fibroids that are sort of in the way sometimes of where we would like blood flow to go. And usually fibroids aren't something that are a problem, but they can be depending on where they're located, how big they are, and if they're protruding into the cavity. So things need to be optimized for a healthy pregnancy. It's just amazing the huge symphony of everything that goes on for a pregnancy to actually happen, with the immune system, with all the blood flow and the development of those spiral arteries that have to develop. So if there are little tweaks sometimes that we can make, that can make the hugest difference to even if there's not, we can't fix everything, even though we obviously can't change their age, but looking for the blood clotting disorders or something that's more rare to look at, that can sometimes still, it doesn't mean that it's rarely there. It's just something that we're not looking for. And sometimes some women don't need that really much treated in order to be pregnant, but other women really will.
Anything else, Emily?
I think that those were the main things I was thinking about.
Okay. I know I kind of monopolized the first 40 minutes with questions, so I'm sorry.
Oh, no, it's fine. I feel like so often, I mean, I could hop around on all of these subjects. I think it's been great to kind of dive in like we have.
Yeah, this has been super helpful. So I guess I want to wrap up with, or kind of have our last focus be about, which I think you've already offered, but solutions and hope and resources. So say I'm listening to this and I'm a woman who's experienced recurrent miscarriages and I'm feeling like, my doctor's doing the best they can, but I'm just not happy with what's been going on. I don't feel like I'm getting, a total picture. And I want to seek, I'm feeling hopeless, but now I'm feeling potentially hopeful that, well, is it really something as simple as my medical professional might not be, trained as much? Like maybe I have just exhausted their resources, because that is definitely my story, not with recurrent miscarriage, but just with reproductive health, of like reaching the point, doing the tests, and then going to the office. And she just very honestly was like, I don't have anything else to offer you but the birth control pill. Like, I don't know what's going on. Which was disheartening because I didn't have another resource at the time. I was like, well, I don't know what to do if you don't know what to do. And then, I was made aware of the Creighton model, and kind of my whole life changed after that. So that was a huge blessing. For the woman who maybe is experiencing that feeling of like, well, my doctor doesn't know what's going on. What should I do next? Where would you want to send them and direct them? And we can list, resources in the show notes for people.
Well, I would say that I know the International Institute for RRM has a great resource, because they have a contact page and they will actually get back with you and find an RRM clinician for you in your area. And they'll probably be able to give you several different resources, because most of the time, because we can do a lot through telehealth, of course, certain things you cannot do through telehealth. You may have to travel if you need surgery or something, or a very specialized exam, but they will be able to help you find something. I currently am with Reply Fertility, and we have locations. Well, we have telehealth in something like 41 states, and we're trying to get it in all 50 states. So it just takes some time to get all those state licenses. We also have, there's My Catholic Doctor. There's the Fem Health has telehealth as well. There's lots of, I would say, independent clinics throughout the U.S. So there are a lot of resources out there, and you could look for those. There's the American Academy of Fertility Care Professionals, and they have a link to a page of clinicians as well. So physicians, physician assistants, and nurse practitioners, all that can be really helpful in your journey. And sometimes it takes a team, and that's what we try and do at Reply. We have a team of NFP and fertility awareness-based method teachers. We have case managers that are nurses. We have our physicians, and we also have a abdominal massage therapist. That's another thing that we didn't even touch on. That is a great resource, actually. Abdominal massage can help with things like sometimes pain, alignment, but even things like the biome. It can alter the biome and it's when you're using someone that when someone is teaching you how to do it, when you have someone that's certified in the methods that are out there, like they can actually know how to do it at home. So it's something that you don't have to see them for the rest of your life. You go in for 3 to 4 sessions. They diagnose some problems. They kind of show you how to do it at home, and then you're able to do that. It's a tool you can use, just like using a fertility awareness-based method for the rest of your life. But sometimes you need to check in and talk to your instructor again as things change. That's the thing that most of us know about our periods and how heavy or light they are. If you're telling us that you are using some LH strips, for example, and you're writing down when your period is, I would say that's probably the basics that a lot of people do in an app on their phone, but they maybe haven't been trained. That's great if you're seeing LH go positive. It's great if you're keeping track of your cycle, but there's so much more that we could know about than just the menstrual part of the cycle, because and so if we get a good picture through a certified teacher with a fertility awareness-based method, you're going to get a lot more information and help your doctor with the diagnosis of what's going on and your treatment. And you're going to see, as your charts look better and more like a healthy cycle, it's going to be encouraging for you too, because that's the way that you can see it happening without even having to visit a lab or going to a ultrasound facility.
Awesome. That's so great. I will link to all those resources that Dr. Barrows mentioned in the show notes for those of you that are interested. It sounds like a great step would just be to start charting if you haven't already. Start getting that pattern down, because like she's mentioned, and like Emily and I have talked about before, the bleed is an important part of the cycle, but there's a lot of other data that we want to be gathering. So learning how to identify your different biomarkers and then get that down on paper, quote unquote, or in an app, but to get that down so that that pattern can start to show. So a physician that's trained can look at that and say, oh, certain things will jump out at them, and they can start to address what they think might be some underlying causes and start to investigate some more. So, okay, I think that's all I have. I mean, I feel like we could keep going, but yeah, I feel like this was just really great. I so appreciate all of your time and your expertise, and that you're just willing to continually work with these women and these couples, because I know you're doing so much good. So thank you. Thank you. Thank you. Thank you. Really appreciate it.
Thank you so much.
Thank you.
All right. You guys have a good day.
Me.
Absolutely. Yeah, anytime. Thank you.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.